Yeah, that's a good question. So the question is, what is the role of SAVR versus TAVR in patients with aortic disease? As we know, there's a transformative technology known as TAVR that has really revolutionized the way we treat patients with aortic stenosis. But the reality is the data that we have is really compelling data for patients who are high risk and inoperable. For patients who are intermediate risk, it's still a little bit unclear. In many ways, it's still a little bit of a coin toss between whether SAVR or TAVR. The data that's been published so far is about 5 to 7 years out. And we know that, in intermediate risk patients, where we expect them to live a long time, hopefully more than 5 to 7 years, we need longer data. And right now, the outcomes are almost head to head regarding SAVR versus TAVR. For lower risk patients, I think most people would probably agree for low risk patients, SAVR is the way to go. And there's some trials out there looking at SAVR in low risk patients. But for the most part, I think one would suggest that in low risk patients, SAVR is the way to go. Yeah, so I think that reflexively, most physicians and certainly patients prefer not to get surgery. No one comes to my office begging to have open heart surgery by any means. So because of that, the reflex and the inclination is less invasive approaches via transcatheter approach, specifically TAVR. So that trend has switched from SAVR to a more transcatheter approach. But I think that with time, possibly as more of the data comes out with TAVR, that it may suggest that in certain patient populations, SAVR is the way to go. And we'll find us backing off a little bit on being aggressive with TAVR in these patient populations. Specifically, I think in low-risk patients, SAVR is the best option. And maybe for intermediate risk patients, it's a little bit debatable, but I'm a little bit inclined to think that that SAVR is the way to go. I would say some of the pros and cons of both. I think that the pro of a potential TAVR is in a patient with a smaller aortic root who is a little bit higher risk. You can get a valve in with probably a little bit better hemodynamics in a small aortic root. That said, if a patient has a small aortic root and is relatively healthy, then I think you can get the best hemodynamic consequence in doing a SAVR and eventually doing a root replacement or a root enlargement on that patient. And that affords a long-term durability in that we know the data for SAVR in 10, 15 years out. We also know that if you do a SAVR, you also preserve the option of later on doing a TAVR inside that surgical aortic valve. We don't have a lot of data with TAVR inside TAVR. So if you decide to put a TAVR inside that patient who is maybe lower intermediate risk, and then that valve fails later on, we don't know the long-term data. We actually have very little data with TAVR inside another transcatheter aortic valve. Yeah, so we are excited to host the structural echocardiographer symposium in Miami for a lot of different reasons. One, I think Miami is a phenomenal place to visit during the summers, during the winters. It's one of the few major cities that's 25 minutes from a major airport, and there's a lot to do here. So I think it's a great place to host a meeting. That said, valvular heart disease is one of those few disease processes that has recently shown a really true benefit from multidisciplinary collaboration. So this meeting is as multidisciplinary as it gets. We have cardiologists who are world known. We have imagers who are world known, and we have surgeons who are world known who come in the spirit of discussion and promoting medicine and advancing medicine to really do a deep dive in some of the controversial topics that we just talked about and really give different perspectives on how to approach valvular heart disease, including aortic valve disease, mitral valve disease, tricuspid valve disease. There's a lot that we know and there's a lot that we don't know. And I think the more we get together, the more we discuss it, the better, and we kind of learn from each other. The only thing I'd like to add, if I didn't emphasize enough, is that we have a fantastic program with people from around not only Miami and Florida, but around the country to come down and really to do a deep dive only on valvular heart disease. And that's kind of rare because a lot of meetings are focused on a whole host of different topics. A lot of meetings are very specialty specific. This meeting is purely dedicated to structural heart disease, valvular heart disease, and bringing in specialists from all different angles to talk about valvular heart disease. So we're looking forward to having very engaging discussions, oftentimes controversial discussions. I think that's when we learn the best from each other. To really ultimately, at the end of the day, is to take this back home to your patients, to our patients, and do what's best and provide them the absolute best care possible. That's data driven and has a benefit of getting the perspective from as many people as possible.